Welcome to the podcast. Today, we're diving into the groundbreaking work of William Masters and Virginia Johnson, pioneers in the field of sex therapy. Their research in the mid-20th century revolutionized how we understand and treat sexual dysfunction.
Absolutely, Jordan. Before Masters and Johnson, sex was a taboo topic, especially in the medical community. Their willingness to directly observe and study sexual response was truly radical. They brought a scientific lens to something that had been shrouded in mystery and shame.
Exactly. They established a structured, directive approach to therapy, primarily focused on committed couples. It's important to remember the context. This was a time of significant social change, with evolving attitudes towards sexuality. Masters and Johnson provided a framework for addressing sexual issues with a practical, evidence-based methodology.
And their approach wasn't a one-size-fits-all. It was modular, meaning that after an initial assessment and what they called sensate focus exercises, the treatment protocols would diverge based on the specific problem the couple was facing. This allowed for tailored interventions while maintaining a consistent set of core therapeutic principles.
Let's break down those core principles. First, problem-specific interventions. This meant that each sexual dysfunction, whether it was erectile dysfunction, premature ejaculation, or orgasmic disorder, received targeted procedural guidance. It wasn't just general advice, it was a specific plan of action.
Right. And the second principle was progressive complexity. The techniques built on each other sequentially. So couples would start with simpler exercises designed to reduce anxiety and increase awareness, and then gradually move on to more complex techniques as they gained confidence and competence. Think of it like learning a new skill. You don't start with the advanced stuff.
Precisely. The third key principle was a collaborative framework. Both partners were actively involved in the therapeutic exercises. This wasn't about one person being fixed. It was about the couple working together to improve their sexual relationship.
Which leads us to the fourth and perhaps most crucial principle, communication. Ongoing dialogue between partners was the foundation of the entire therapeutic process. Masters and Johnson emphasized open and honest communication about feelings, desires, and concerns. It was about creating a safe space for vulnerability and connection.
It's worth noting that their approach was quite behavioral in nature. They focused on observable behaviors and specific techniques to change those behaviors, rather than delving deeply into past traumas or psychological issues. While that approach has evolved over time, their emphasis on practical techniques and communication remains influential in sex therapy today. Let's delve into the Masters and Johnson protocol for erectile dysfunction, often referred to as impotence. The core of their approach is a strategic redistribution of performance responsibility.
So, what does that redistribution actually look like in practice?
It's about shifting the focus away from the male partner's perceived obligation to achieve and maintain an erection. The anxiety surrounding this performance can actually be a major contributing factor to the dysfunction itself. Think of it as a feedback loop. Anxiety leads to difficulty, which in turn increases anxiety.
Makes sense. So how do they break that cycle?
The female partner takes the lead. She receives specific instructions on penile stimulation techniques. The goal here isn't just physical stimulation, but also psychological reassurance. Once an erection is achieved, she initiates vaginal insertion.
And the male partner's role?
He adopts a receptive, non-demanding posture. He's essentially relieved of the pressure to perform. The female partner controls the timing and movement, allowing the male to focus on sensation and pleasure without the cognitive interference of performance anxiety.
So it's a reversal of traditional roles, at least temporarily. What's the theoretical basis for this?
It's rooted in the idea that the pressure to perform is a primary cause of erectile dysfunction in many cases. By removing that pressure, the intervention allows for relaxation and a return to more natural physiological responses. It's about decreasing the cognitive load associated with sex.
Can you elaborate on that cognitive load?
Sure. Imagine trying to solve a complex math problem while simultaneously trying to run a marathon. Your cognitive resources are divided, and neither task is likely to be performed optimally. Similarly, when a man is overly focused on achieving and maintaining an erection, it can interfere with the natural processes of arousal and erection.
So what are the expected outcomes of this approach?
Ideally, we see a reduction in anxiety-related erectile dysfunction, a restoration of erectile capacity through decreased cognitive load, and a reestablishment of sexual confidence in the male partner. It's about creating a positive feedback loop where success breeds further success and reduces anxiety over time. The goal is to help the couple rediscover intimacy and pleasure without the burden of performance expectations. Let's delve into the Masters and Johnson approach to premature ejaculation, focusing on the squeeze technique. It's a behavioral method, meaning it relies on learning and modifying responses, and it demands a high degree of teamwork.
Absolutely. The core of the squeeze technique is teaching the male partner to recognize the point of ejaculatory inevitability, that moment when he knows he's about to ejaculate and can't stop it. Communication is key here. The male partner needs to clearly signal to his partner when he reaches that point.
Exactly. Then the female partner applies firm pressure to the penile tip, specifically where the glans meets the shaft. The pressure should be strong enough to inhibit the ejaculatory reflex, but not so strong as to cause pain. Think of it as a controlled interruption.
It's like hitting the brakes on a runaway train, but gently. The pressure is maintained for a few seconds, usually 3 to 4, until the sensation to ejaculate subsides. Then, both partners pause sexual activity for a short period.
This pause is crucial. It allows the arousal level to decrease slightly, resetting the cycle. After the pause, sexual activity can resume. The process, communication, squeeze, pause, is repeated multiple times during a session.
And consistency is paramount. Masters and Johnson found that couples typically need several weeks of regular practice before they see significant improvement in ejaculatory control. It's not a one-time fix, it's a learned skill.
It's also important to emphasize that partner cooperation is essential. Both individuals need to be fully invested in the process and willing to communicate openly and honestly. Any resentment or lack of commitment can undermine the effectiveness of the technique.
The success rates speak for themselves. Masters and Johnson reported a 97.8% success rate with the squeeze technique, making it one of the most effective treatments for premature ejaculation. And compliance rates are high because the procedure itself is relatively straightforward.
It's a testament to the power of behavioral techniques and the importance of partner involvement in addressing sexual dysfunctions. The squeeze technique offers a tangible, actionable approach to regaining control and enhancing sexual satisfaction. So, with female orgasmic dysfunction, Masters and Johnson really emphasized a woman's journey toward understanding her own body and pleasure. It's not just about achieving orgasm during intercourse, but about developing a broader sense of sexual self-awareness.
Exactly. The superior position, or woman on top, is key here. Think about it. Traditionally, the man dictates the rhythm and depth. This position flips that script. It allows the woman to explore what feels good, to control the pace and angle, and to really connect with her own sensations.
It's about agency. Many women, especially in past generations, were taught to be passive recipients during sex. This intervention actively challenges that. It's like saying, okay, you're in charge now. What do you want?
The theoretical rationale is fascinating. If a woman has primarily experienced sex from a passive perspective, she might not even know what stimulates her most effectively. The superior position allows for direct experiential learning. She can feel the effects of different pelvic movements, explore various levels of clitoral stimulation, and discover her unique pleasure map.
And the absence of orgasmic demand in the early phases is crucial. It removes the pressure to perform, which can be a major roadblock for women experiencing orgasmic difficulty. It's about exploration without expectation.
Think of it like learning a new skill. You wouldn't expect to master a musical instrument overnight. It takes practice, experimentation, and a willingness to learn. The same applies here. The graduated progression, the repetition across days, it's all about building that experiential knowledge and confidence.
And communication is paramount. The woman needs to be able to communicate what feels good, what doesn't, and what she wants to try. It's a collaborative process, a journey of discovery that the couple undertake together. It's not just about the physical act, but about building intimacy and understanding. Looking at these protocols side by side, it's striking how each one directly confronts a specific anxiety or dysfunctional pattern. For erectile dysfunction, it's the pressure to perform. For premature ejaculation, it's the lack of control. And for orgasmic dysfunction, it's often a history of passivity.
Exactly. And the interventions are cleverly designed to reverse those patterns. The erectile dysfunction protocol shifts the focus to the female partner's stimulation, relieving the male's anxiety. The squeeze technique gives the couple a tangible method to control the ejaculatory reflex. And the female superior position empowers women to explore their own sexuality actively.
It's also interesting how communication is woven into each protocol. The male has to communicate the urge to ejaculate, and the female has to provide feedback during stimulation. It's all about open dialogue.
Absolutely. Masters and Johnson really emphasize the importance of partnership and mutual understanding in sexual health. Their legacy is undeniable. They brought sex therapy out of the shadows and into the realm of scientific study and clinical practice.
And their emphasis on behavioral techniques and communication skills remains highly relevant today. While contemporary sex therapy has evolved to incorporate more nuanced understandings of psychological and relational factors, the core principles of targeted interventions, progressive complexity, and collaborative frameworks are still foundational.
You see elements of their approach in cognitive behavioral therapy for sexual dysfunction, mindfulness-based techniques, and even some of the newer somatic approaches. They really laid the groundwork for a more open and effective approach to treating sexual problems.
Their work also highlighted the importance of addressing sexual issues within the context of a relationship. It wasn't just about fixing a problem, but about enhancing intimacy and communication between partners. That's a perspective that continues to resonate in modern sex therapy.
And let's not forget their groundbreaking research. They were pioneers in observing and documenting the physiology of sexual response, which helped to demystify sex and challenge many long-held beliefs. Their work paved the way for future research and a more evidence-based approach to sexual health.